This is Outcomes, a show about uncovering the hundreds of micro-innovations that help make Australia's healthcare system one of the best in the world. On the show, you'll meet the doers, the Australian clinicians, care workers and healthcare professionals driving the micro-changes we seek to showcase. Theirs are the stories we're here to tell. I'm your host, Will Egan, and I'm the CEO of AusMed Education. I'm really passionate about improving the health and prosperity of the people in my community. I believe Australia does have a great health system, and every conversation we have on this show highlights why. Scope of practice, the virtual or conceptual boundary that we place around ourselves or others to control, limit, and manage the roles or skills a clinician or carer can perform as part of their job. That sounds like a pretty black and white definition, yet scope of practice is far from that. Today, I'm joined by Kate Rowan-Robinson, a true thinker, clinician, and all-round emerging leader in Australia's healthcare system. Kate has spent her storied career managing scope of practice and really trying to get to a definition around how you expand it and evaluate someone's ability to perform within it in a safe and competent way. Kate oversaw a large part of the nation's clinical governance framework that enabled nurses to administer COVID vaccinations during the pandemic. And in today's conversation, through a review of this and a number of cases, we explore this topic in depth. It's a great conversation, so without further ado, let's jump in. Well, Kate, it's great to have you on the show. Welcome.
Thank you, Will. It's a pleasure to be here.
I think today's going to be a really interesting conversation. I'd love to start by asking you to introduce yourself and tell us a little bit about your background.
Yeah, sure. So my name's Kate Rowan-Robinson. I'm the chair of the Nursing Regulation Faculty, the Australian College of Nursing. Strangely, I have an interest in regulation, which is what not a lot of other people have an interest in.
I know, it's got a little bit of a reputation as to being a rather dry or boring topic.
Yes, boring.
Yeah.
People think it's boring.
But you don't. And having been to your talk at the ACN's National Nursing Forum earlier this month, I don't either. I think it was fascinating, and I'm really appreciative of you being offering to be on the show today to show to others why it's not boring and just how interesting it really could be. So tell us a little bit about how you got to become interested in regulation.
Yeah, so by way of background, I'm a primary healthcare nurse. I've been working in many different areas of primary care for a number of years, and I ended up doing clinical governance for a corporate health organisation. It's a national organisation, and we worked in a number of specialty areas as well. So when we were developing, our policies, our procedures, our protocols, etc., we had to take into account a really large number sets of, regulatory mechanisms, legislation. Every state and territory is regulated differently in terms of health, and they can be dramatically different. And so trying to bring all of this together to have harmonised policy, procedure, etc., across a national organisation was quite challenging. And along the way, I found that we had nurses who didn't always understand how they were regulated and, be trying to work with them in terms of their scope of practice, saying, hey, you can do this, or hey, you can't do this. And so really had to demystify a lot of regulation. And that's sort of where my interest started. And it sort of just went from there. And now it's ended up here.
Yeah, fantastic. So you chair or lead the kind of policy group at the ACN, the Australian College of Nursing, on regulation, is that right?
Yes, that's correct.
Awesome. And that group is essentially a committee of members. Is that the case?
Yeah, so we have an incredible committee, to be honest. They are absolutely fantastic and extraordinarily experienced in the area. So there's a leadership team of 4. And we get together and we talk about the regulatory mechanisms or the regulatory hot topic of the day that's going on. We are currently getting up and running, so we'll be starting to deliver some more presentations, webinars, education in this space to really promote what regulation is and what it means to nurses and how they can use regulation to support their safe practice.
I think that's a good place to start, what regulation is and how it can support a clinician in their practice. This is a bit of a basic question, but why do we need regulation? Where does it come about in a healthcare service, and at what level does it start flowing down from? Like, where's the top of the regulatory model or framework?
Where's the top? So, of course, that all sits with AHPRA. So, AHPRA is our regulator for nurses in Australia and other healthcare professionals as well. So, they determine what our standards for practice, our code of conduct, our ethical standards as to which we have to adhere to. And the regulatory goal of AHPRA is to protect the public. So, no matter what we do as nurses, we are always operating to ensure we're protecting the public. So that's where it starts at the top, and then it sort of flows down from there. And so we go through a number of different mechanisms to ensure that nurses can practice safely. And we're a really large workforce. There's about 450,000 nurses in Australia at the moment. So a lot of it is voluntary regulation. And what I mean by voluntary regulation is nurses voluntarily choose to adhere to their scope of practice, to the standards for practice, their local policies, procedures of the organisation that they work for. They look to their local health district policy procedure, et cetera, et cetera. So from all of that, that sort of brings together, how nurses work day to day and what regulation means for them. And ultimately to guide that, it's keeping the public safe, keeping our patients safe.
Absolutely. So if we move into the heart of regulation or a regulatory model for a group or a workforce, I think what seems to sit at the centre is this concept of scope of practice, which seems pretty amorphic or hard to put your finger on. But it also seems like a topic that people find it difficult to talk about.
Yeah.
What's been your experience with scope of practice and having those conversations, or how do people think about that concept?
Yeah, I find it really interesting because particularly for nurses, our scope of practice is incredibly important to what we do, and it regulates everything we can or can't do. So, and every nurse has their own scope of practice. So you're never going to run into two nurses who have exactly the same scope of practice. It's just not going to happen. And the thing is, so you're taught from nursing school, day one, you have a scope of practice and you do not step outside your scope of practice. If you step out of your scope of practice, bad things will happen. And so you sort of taught this concept. And the NMBA, they've got a great decision-making framework that nurses can use to help determine their scope of practice and as to whether they can or cannot proceed with performing tasks or certain roles or duties. And, I sort of try and bring it into a bit of a nutshell. Are you competent? Are you confident? Are you authorised? And they're three really important questions to determining your scope of practice.
So that's, are you confident, are you competent, and are you authorised? And all three need to be true.
You've got to be all three, yes. So you just can't be very confident you can do something and give it a crack. You need to be competent and you need to be authorised as well. Authorised is a really interesting concept too, because as I've mentioned before, that health is regulated by the states. And so every state and territory have really different regulatory mechanisms of what you can and can't do. So what a nurse might be authorised to do in the Northern Territory, they may not be authorised in Victoria. So it's really important to understand that even though you're confident and competent at this particular activity you want to perform, you may not be authorised. And so therefore it is no longer within your scope of practice. And that can be as simple as moving across state borders as to how your scope of practice works. The thing I find fascinating is I feel like we're all, as nurses, we're all required to know our scope of practice. And we all kind of go, yeah, I know I shouldn't do this and I know I can do this. But we don't talk about what actually makes something our scope. Where does our scope come from? How is it determined? And we have this decision-making framework from the Nursing and Midwifery Board that can help guide us through. But I feel like scope of practice is almost this uncomfortable sort of conversation where we all go, yes, we know it's our scope of practice. It's who we are as nurses. We have a scope of practice. But if you started to really try and drill down, I think conversation becomes a little less comfortable because you're starting to really have to self-assess and examine my skill set, my capabilities. I think authority is an interesting one. I've had very interesting conversations with nurses in the past about what they think they're authorised to do. And sometimes they think they're authorised to do things that they're not actually authorised to do. But conversely, I've seen the opposite end of the spectrum as well, where I've seen nurses working for facilities or for employers or, healthcare providers, and they've been prevented from using their full scope of practice because there's a belief that nurses cannot do that task. And, I often refer to an example where I was trying to get a lot of nurses trained up to be suturing. It was sort of in the best interest of everyone if nurses could be suturing. And I had some nurses try to tell me that no, nurses can't suture. And I'm like, what do you mean nurses can't suture? why not? If they're given the required education and, the training and the oversight to do so, and there's lots of different ways you can do that. But if someone goes to a suturing course, they sit the course, they're assessed, they practice under supervision, for example. So they're starting to go through that process of going, okay, I'm competent, I've gone through a course, I'm not yet feeling confident, so I'm going to have, some oversight from, from another more experienced nurse or a doctor until I get my confidence and I'm authorized to do this task. So that's, bringing it into their scope of practice. So it's interesting when you talk to nurses, because you can see very broad and very different ends of the spectrum, where some are very risk averse and don't think nurses should be performing certain tasks. And then you get the opposite end, where we start to get a little bit cowboy and, there's an understanding that, I can go do all these things, but perhaps you haven't looked quite into that authority side as much as what we should do.
That's interesting. So with the authority side, it sounds as though there's this implied boundary or perimeter around the skill set of a nurse. But I'm guessing that there's a whole lot of things written in regulation, whether that's at a state or federal level, and then there's a whole lot that isn't.
Yes.
So there's a grey area.
Very grey. Very, very grey, yeah. So when you're looking at scope of practice isn't just determined by any one thing. So you've got your legislation that sits at the top. We've got our regulatory mechanisms that sit underneath. So that's where you look for your standards of practice and your code of conduct and your code of ethics. And then underneath that, you've got state-based, legislation, regulation, and all your mechanisms there. You'll have your local district health bodies, because the scope of practice, or what influences a nurse's scope, is very different in a metro area than it is for, Aboriginal communities or, the remote, Kimberley or somewhere like that. Those nurses are going to have really different scopes just by virtue of access to services. So you might authorize things to take place in remote areas that you're not necessarily going to authorize in a metro area, because there's no need. So, health need can determine scope of practice to a degree. So you've got all of that. And then it comes down to, it sort of starts filtering down. So you'll have district-based policy procedure, and then you'll have facility-based policy procedure and authorities. And it was interesting because when we were at the nursing forum, I had a nurse raise a really interesting point, whereas she's normally an ED nurse. And in ED, they have nurse-initiated medications and they have structures in place to support that. She was asked to go do a shift on another ward, and she gave a patient some nurse-initiated ibuprofen after she assessed the patient, did all the things that she's supposed to do, determined the patient needed the ibuprofen, it was safe to administer. She went ahead and gave it, and she got into trouble. And they just said, well, we don't do that on this ward. It was the same hospital. It was exactly the same hospital. It's a task that she'd performed. She'd done nurse-initiated medication. She was competent. She was confident. She was authorized in her emergency department. She was not authorized on this ward. And so that changed her scope just by going to a different ward, which is crazy. But it is. And that was, it's confusing and it's very grey, because things like that can happen. She's doing a task that she's done for a very long time, but just by virtue of moving to a different ward, it was no longer in her scope.
That grey as well seems to start when government regulation stops and it becomes open for kind of interpretation. And
absolutely, yeah.
And then we seem to move into this realm of, I guess, like clinical governance, essentially policy and procedures, appetite for risk, perhaps.
Yes.
Can you talk to those factors?
Yeah, risk appetite can definitely determine nursing scope of practice just by virtue when you've got people who are writing policies, procedures, deciding what a facility, and when I talk about facilities, it can be anything from a very small GP practice or community health centre right through to your big tertiary hospitals. So I talk a lot about facilities because it sort of captures everyone into that one term. But, it can depend upon the risk appetite of an organisation. And, I've seen it a lot in primary care services, where you can work in some clinics where you've got an employer who really wants their nurse to be doing anything and everything, and they'll be really pushing that nurse to be doing things, and sometimes to the point things that the nurse can't do. And, the nurse has to stop and say, hey, this is not my scope of practice. I cannot do this thing for whatever reason. But you can have it right to the opposite end. And I have seen it where with, such risk-averse providers, I've seen nurses prevented from administering immunisations or, doing wound care you want to talk about two things nurses do really, really well. It's immunization and wound care. It doesn't make sense to prevent a nurse from doing that. But their employer just decided that the nurse should not be doing those things, and it impeded her scope, which was really sad. But that's where their risk appetite was at. And there's a lot of work there that needs to be done to educate that employer to say, the nurse is trained and should be doing these tasks. They're important nursing tasks.
So in that example, just to pull on that thread a little bit, as a nurse in that workplace where maybe I do have 10 years of experience of wound care, how do I advocate for myself? Where do I go? Who do I speak to? How do I drive that change myself? And I think examples of this maybe even kind of cross into the nurse practitioner world, where there's a lot kind of higher or additional set of responsibilities that a nurse practitioner can take. Yet they seem to be constantly limited by what their employer kind of permits them to do. Or, is that a true characterization?
Yeah, it is. And look, I think it's also, and this is where I think it's, really advocate, we need to talk about regulation. It's really important. We need to understand how we're regulated. And it's not just us as nurses, but it's also about making sure our employers and say our facilities, et cetera, understand how we're regulated, because we get an idea. And, it's interesting. Like I remember, talking to a nurse who rang me one day and said, oh, we've got an enrolled nurse, and are they allowed to administer Ventolin? I'm like, of course they're allowed to administer Ventolin. Why would you think they can't? Is there an issue with the scope? Are there conditions on this nurse's registration that prevents them from doing so? And they go, oh no, just back in my day, enrolled nurses were just starting to administer Ventolin and Panadol, and so now I'm not really sure where it's at. And I'm going, well, enrolled nurses are being trained to do IVs now, so, we've come a really long way in terms of scope. But you really have to educate and ensure that people understand that those regulatory mechanisms. And in advocating in these situations where a nurse is being prevented from working to their full scope. And I find this really interesting because we've obviously having this big scope of practice review into primary care at the moment, and really trying to look at, how do we most effectively use our health workforce? It's a limited resource, where in this real time of, health practitioner shortage, if you talk to anyone and say, do you think your ward is fully staffed or your facility is fully staffed? A lot of people are just going to say no. And then trying to hire and find these nurses is really challenging. So we want to use health practitioners to their full scope. It's really important that we do. But also we've got this duty to protect the public and ensure that we're practicing safely within our scope. But particularly when advocating in these risk-averse environments, if that's where you happen to be, understanding how you're regulated can really help you put forward how you can safely perform a task, because we have to remember patient safety is key to everything we're doing. So we've got to get back to that principle of we're protecting the public when we're working as healthcare practitioners. And so I've got to ensure that if I'm going to take this task on or this duty, or I want this responsibility, how are we going to perform it safely?
The keystone in this kind of bridge, this connection between regulation and empowering a clinician to act on these things within their scope of practice seems to be a workplace policy and procedure.
It's part of it.
It's part of it. Okay.
It's part of it. Yeah, it's part of it.
It seems to be quite a critical part, though, based on
yes, it is.
What else is sitting there alongside that?
So you need to have your policy and procedure in place. And I know people get irritated by policy procedure. You go, oh, you got to check the policy. You've got to work to policy. I don't agree with the policy. I don't like the policy. The policy is the policy. If you have a problem with the policy, you need to talk to the person who wrote the policy and, tell them why you have a problem. And hopefully, it may be completely legitimate and they just don't know it's a problem. You need to go to them and have it change. Understanding your position description is a really important component of scope of practice. You're being employed to do a certain job, and referring to your position description will help guide what your scope of practice will be or is expected to be or should be. CPD informs scope of practice, making sure, obviously there's the mandatory component of CPD. So that's the regulatory component where you have to do your 20 hours of CPD every year. That's really, really important. But CPD is also really important for developing your scope of practice or ensuring your scope of practice stays current. I know at the Nursing Forum, I made the example that, back in, I think, 2012, I did an Implanon course and I got a certificate that says I can, insert an Implanon. I don't think I've inserted an Implanon for well over, I don't know how many years. And for me to say now that I'm authorized, I am technically authorized to insert an Implanon, I wouldn't go ahead and proceed with that. But if I recognized, for example, that I had the certificate to do implant-ons, I can insert them. I was competent, I was authorized, I felt confident. But say I hadn't inserted one for some time and my confidence was starting to wane, it'd be up to me then to utilize my continuing professional development to do a refresher course or to, seek further advice, to talk to my employer and say, hey, it's really important. I have this skill, but I'm not doing it very often. Can we arrange for me to have some supervised practice, using your continuing professional development to do that? So that's a really important mechanism as well. So making sure that you're aware of your policies and procedures, your position description, undertaking your continuing professional development. But it's also important to understand that the policies and procedures that affect you as a nurse, it's not just your individual facility. You've got to look to your local health district and your state as well. And there's a really good case in relation to this. It was in New South Wales some years ago where, there was a patient incident. It was incredibly tragic, this patient incident. And what had happened was the nurses ended up before the tribunal. So the example being that, these nurses argued that they weren't responsible for this clinical incident that occurred that had an incredibly tragic outcome because they technically followed an observation policy where they were supposed to do observations in a certain time frame. And they technically completed the observations. But the problem being is that even though they technically completed them, they didn't explore their findings, and they should have explored them. They should have done further assessment to ensure that the patient was receiving the care they required. And they argued on that technicality that they shouldn't be reprimanded because they technically met the requirements of the policy. The observations were performed, but they never assessed them further and they never acted upon them. What they didn't realise was there was a local health district policy that actually went a little bit more into detail about the purpose of the observations and what they were expected to achieve. And it was about supporting patient safety. But the other component they missed as well was referring to their standards of practice, where it talks to patient safety. You're acting for the best interests, of your patient and what is expected of you. If you have an assessment finding that makes you question something, what how a registered nurse or even an enrolled nurse is expected to act. So it's not just the policy. You can't just rely on the policy. You can technically perform an action in a policy, but it does not necessarily mean that you're working to a standard where the public is protected, which is what is expected of you as a regulated health professional.
When things do go wrong like that, how does a nurse or that group of nurses, how are they protected? Because I think the assumption we all make, and it's safe to make this assumption, is, people are providing care with the best intentions.
Yes.
We see this in those unregistered workforce group cases where there's a lot of good intention.
Yes.
That is actually almost the cause of the misstep sometimes.
Yes, it is.
So working under that assumption, what protections exist for someone in that situation?
Look, I think it's really important. It's really challenging, and I really feel because, the pressure upon nursing as a workforce is enormous, and there are nurses working outside their scope of practice all the time. And, you talk to nurses, they go, I'd never work outside my scope of practice. And I think we all know we've all worked outside the scope of practice. I've talked about stories, and I think it's important we're having these discussions. It's really, really important we are, because they are uncomfortable discussions. You get that, and it's hard, and you don't want to sort of tell someone your dirty scope of practice secret and find yourself inadvertently reported to AHPRA, which you can't do. It's not a mandatory report. But it is really important to be having these discussions and to be sort of starting to talk about this regulation. And like you say, where do we go? Because it's a really lonely place. If you find yourself in the position where you're getting a please explain, and whether that's from your employer, whether it's from the regulator, it can feel very, very lonely. And where do you go to get advice? And there's not a lot out there. There's a 24-hour nursing and midwifery support line. People can call that. They can, seek some advice and some support there. Nurses who are a member of a union, they can go to their union and, ask for advice and support. But, in terms of being able to reach out to your peers and to say, this thing has happened and what should I do and how should I manage this? There's really not a lot out there for nursing. And I find it interesting, our medical colleagues have a lot more support in this area, whereas nurses, we don't have that. We don't have that objective place where you can go and say, I've found myself in this position, and sometimes I've made a boo-boo. Sometimes it is my circumstances where when this shift or this event happened, it was just really bad and it was a complex patient and then these things happened. It can be sometimes the policy is not great because, I've written bad policy before. I've had to go back and change it. Like, I'm not going to pretend I'm the best policy writer in the world. I've written some policy that didn't work. And, I relied on the nurses on the ground to tell me my policy wasn't working for them. But it can be a very lonely place. And, I've seen responses that, nurses can get very defensive. And I can understand why. We're the most trusted profession in Australia. We have a significant reputation upon us to be outstanding at what we do all the time. And that's a lot of pressure. And sometimes things don't go right. And being able to be empathetic to the nurses around us to say, sometimes these things don't go right, but what are we going to do? And, really reflecting carefully on what has happened and what could we change to make sure it doesn't happen again. We're still not quite there where we talk about our errors, we talk about our mistakes, we talk about what we could have done better at the time. And these situations happen all the time. I remember back when I used to work in the hospitals, and I remember particularly one shift where I was sitting there thinking, if anything goes wrong, I could end up before the regulator. And I feel very powerless right now because it was just circumstances, the type of patients we had. It was just, I don't know, maybe it was a full moon influence or something like that, but it was frightening. At the time, I thought anyone could report me tonight and I don't really have much of a case to answer. And I think we need to be talking more about that and what does it mean and what if something had happened and what could I change to try and prevent that from happening again? We need to be having more of these conversations. But the interesting thing is, and I think it's really important to point this out, that overall for nursing, we're the largest health workforce in Australia.
I'd almost think you're the largest single workforce.
It's an enormous workforce, yeah. And look, this information is publicly available. Anyone can look at this. You can actually go to the NMBA website or the APRA website and you can look up all the tribunal decisions that have gone through. Now, there's a separate mechanism. Queensland and New South Wales do manage their notifications differently, so you might not see all the tribunal cases on the APRA website. But you can go and see and you can have a look. And in terms of nurses working outside their scope of practice, the cases are few and far between. They often don't end up before the regulator. And the ones that are before the regulator, they are quite significant, where things have really gone quite poorly. I think a lot of scope of practice stuff tends to be managed at a lower level, often within facilities and by employers, which most of the time is an appropriate place because you've got to remember the mechanism of APRA is to protect the public. And if you can address a patient safety issue at a lower level and fix the problem, there is no need for it to go to APRA. If you've got someone who, for example, the nurse who administered Panadol as a nurse-initiated medication on a ward where she technically didn't have the authority. Now, you could report that to APRA if you like. You've departed from your standard. Is it useful? Is it a good use of resources? No, it's not. It is much more effective for someone just to say, hey, we don't do that here. Please don't do it again. And it's unlikely they're going to do it again. Now, if that nurse continued to do so without having that authority, then we've got a different situation. Then we've got someone who's, who's continuing to practice in a manner in which they're not authorized to do so, despite having those discussions at that level. And that's when you start going, now is this a patient safety thing? But most of this doesn't seem to get to APRA. I don't sit on a board. I've got no idea of how many notifications are made about nurses in total every year. But, in terms of what's actually made it to a tribunal in the context of a massive workforce, there doesn't seem to be, all that many in that context. And a lot of them are more about things such as patient boundaries, misappropriation of medication, health impairments, that kind of thing. You see a lot more of that than actual nurses because they've practiced poorly.
The takeaway that I'm having is this grey area of scope of practice, which we kind of just, it's almost like a platitude, right? We refer to, or there's this concept called God terms. I'm not sure if you've heard of this before, but what they are is things that you say so often that they've lost meaning, right?
Yeah.
And then when you try and ask somebody to define what it means, they can't really give you a specific answer or whatnot. Another one is evidence-based. So
yes.
We get that a lot at Osmond. We talk about evidence-based resources or education. It's like, but what would it be if it wasn't evidence-based? Like, it's this kind of filler word, right? But It doesn't mean anything, but it sounds good and people think, oh, it's evidence-based. It sounds really good. So it These
Sounds
ones are
good. Yeah, it sounds
evidence-based.
fancy.
Yeah,
It sounds official. Like, when you say
yeah,
it's official. Best practice is another one. I'm working to
yeah,
best practice, best practice standards. It's like, okay, we all want to work to best practice. So we come to healthcare because we care about people. We want to do the right thing by them. We want them to get better. We want to do all those things. But yes, it feels really nice when we say we're working to evidence-based best practice. It's
yeah.
and it's well, what is that actually, and what does it mean? And scope of practice sits in there as well. I think, yeah, I would agree with that. Is that grey kind of what does it actually mean?
What does it actually mean? And maybe your answer, if you're a clinician, is a combination of or it's at least the things that you're confident, competent, and authorized to do, but the combination between what your workplace allows you to do, what your regulatory environment allows you to do, between your LHD, local health district, a government, federal or state, your position description, so your employer. So there's
It's a lot of moving parts.
But in the pursuit of all health professionals, they're essentially trying to move up it's almost like a little bit of a pyramid to higher skill, higher competence tasks.
Yes.
So say nurse practitioner is the pointy end of the spear there
Yes.
in the nursing kind of workforce, and do more things and work to their full scope of practice. Yeah. So that kind of seems to have this effect of challenging those boundaries
Yes.
as well.
Yes.
Which then we had Leanne Bowes, the CEO of the ACNP, on the show, and she obviously talked about MS two-step, as an example of that kind of going full circle and now being regulated to.
Yeah.
So what's the future for scope of practice in nursing, and maybe even to throw a bit more of a curveball at you, like where's this going over the next 5 to 10 years? What do you think we're going to see? And I'd be interested to hear if you could comment on anything about the care workforce. So there's 800,000. So we've got 400,000 nurses, but between disability and aged care, there's an estimated maybe, let's say 700,000 conservatively, people on those Cert 3, Cert 4, like Certificate 3 of aged care disability support, who are also trying to push their scope of practice, maybe encroaching on the role of an enrolled nurse, perhaps.
Yeah, look, I think the reality of the situation is, we've got to remember, we've got to always have in the back of our mind, protect the public, patient safety. That is first and foremost. And, when you sort of look at that, it's about being practical. I'm a really pragmatic person. So, I'm not actually an academic. Say I've come sort of my journey through just experience and, further study. And, I ended up, going into health and medical law as a specialty. So, it's a really tough one. I think there's going to have to be a degree of practicality. And I think when you look to, and I think probably enrolled nursing's a good mechanism to look at. When you look at enrolled nursing, and we talked briefly about, back in the day when they couldn't give any medication at all, but then it sort of changed and they said, okay, well, they can give Ventolin, they can give Panadol. And that becomes a necessity thing. It's not practical to have the registered nurse always giving out Panadol. And, in the same way, it's not practical for a registered nurse to constantly ring a doctor to ask, can I give 2 Panadol? When you've got the training and skills to be able to make that assessment safely in certain contexts. So, we went from, enrolled nurses and then nothing bad happened. So then, okay, well, let's open it up. Let's do more pharmacology training for enrolled nurses. And then they've done more and more pharmacology training. So then they could give some medications, but they couldn't give IVs. That required a different level of training and skills. Whereas enrolled nurses now are being trained in IVs. So they can do that. And they've got that additional scope. The regulatory framework is changing. And, I think a lot of it will be driven by administrative burden and whether anything bad is happening. And I think there'll be a lot more assessment of these people are doing these things. If nothing bad is happening, and if there's a lot of administration for someone who doesn't want to be doing the administration, we'll change the rules. Like, that's probably the practical thing. I hope I don't get backlash for that.
Yeah.
But for me, in my pragmatic viewpoint, that's how I see it, is that if nothing bad is happening and if it's creating an administrative burden somewhere, they'll want to relieve that administrative burden in the knowledge that to this point in time, there will be evidence to show that, yes, this is being conducted safely by a different workforce. But it's ensuring, again, you've got to have those frameworks in place to support those workers because nobody wants to make an error. And I think that's a really important thing to remember. People don't go to work to make an error. That people who find themselves in this situation where they have made an error or where an incident has happened, they are devastated. It is life-changing. It is frightening. The experience they go through is horrendous.
It's a traumatic experience.
It is a very traumatic experience. And it's not just the fear of the regulator. It's that person they're caring for, that they're responsible for. It really it really affects them. So I think it's important to ensure that those structures are in place to allow patient safety. And then when you've got those structures in place, when things can work effectively, and if they are working effectively, and we don't have that requirement for all that administrative burden for whatever that might look like, that's when you'll see things change. I would love to see a greater understanding of regulation, nursing regulation out there. I feel like there's a lot of stuff that nurses could be doing. They're competent and confident, or they have the skill set or can be given that competence or confidence quite easily to do certain things, with mechanisms that are already available to us. I don't think we need to necessarily be making enormous changes to get nurses working more efficiently and more effectively and safely. But it's that authority that we need to sort of look at.
That's really interesting. I think, so there's systemically a mechanism exists to support, but the parameters are the variables that need to be changed over the years ahead. And that's good, because that's less work than trying to build the system in the first place.
That's the part that I think sometimes for certain things, obviously we have to rebuild in other areas. There are things where you need new frameworks and new structures, but I think there's a lot of things that, if we looked at in a bit more detail and, people were able to look into it a bit more closely, that you could make things work with what mechanisms are currently already available.
Yeah. All right. Well, Kate, before we finish, I'd love to just give you an opportunity to kind of direct people to anything that they might find of interest if they wanted to learn more or get involved with the committee at the ACN. Is there anything you'd like to share there?
Yeah, sure. If you want to reach out to us at the regulation faculty, we'd be delighted to hear from you. We love talking regulation. Please sign up to the faculty. We'll have some webinars coming up soon. We're planning one. I think it'll probably be late October, early November now, but we'll be looking at social media and the impacts of social media and how you're regulated and what you can and can't do there. So please sign up, ask your questions. We'd love to hear from you.
Fantastic. Well, thank you so much for joining us, and thanks for sharing all your experience and wisdom with us over this past hour or so.
Thank you for letting me talk about regulation.
No worries. Thanks, Kate.
Thanks.
You've been listening to Outcomes, a show about uncovering the hundreds of micro-innovations that help make Australia's healthcare system one of the best in the world. This podcast is produced by AusMed, one of Australia's leading providers of educational content and software to the health, aged, disability, community and allied health sectors. To find out more, head to our website, ausmed.com.au. To make sure you don't miss an episode of Outcomes, be sure to subscribe to or follow the show in your favourite podcasting app. And while you're there, please leave us a 5-star review, as it really helps others to find the show. I'm Will Egan, and I'll see you next time for another episode of Outcomes.